It is December 14th, 1799. George Washington is asking for more blood to be taken from his arm. He has been sick for 2 days, with a swollen throat that is closing by the hour. The 3 physicians circling his bed have already opened a vein once before dawn. They open it again, then again. By the time the day is finished, Washington's own doctors have drained close to 40% of his total blood volume. Medical historians estimate that figure based on the accounts left behind. He dies that night. For 2 centuries afterward, most people who learn this fact walk away with the same conclusion. They assume bloodletting was pure superstition, a Dark Age relic with no basis in anything real. They assume it was a practice we were smart enough to leave behind the moment medicine grew up. Here is the part that does not fit that story. Walk into a modern hospital's microsurgery unit. There is a real chance you will find a jar of live leeches sitting in a supply refrigerator. They are waiting to be used on a patient this week. The tool never actually left. It just got a much smaller, much more specific job. Understanding why takes us all the way back to a Greek physician who died over 2,000 years before George Washington was born. Hippocrates, working around 400 years before the Common Era, proposed that the human body ran on 4 fluids: blood, phlegm, black bile, and yellow bile. Health was simply these 4 staying in balance. Galen of Pergamon, writing a few centuries later, turned that idea into a full medical system. In Galen's version, blood was the dominant humor, the one most likely to build up in excess and cause disease. Too much blood meant fever, inflammation, restlessness, practically any symptom you could name. The fix was obvious inside that logic. You remove the excess. For over 1,000 years after Galen, doctors across Europe treated a vein opening the way we treat taking an aspirin today. Routine, low stakes, something you did before symptoms even got serious. Barbers did much of this work alongside actual surgeons, since barbers already owned the sharp tools. The red and white stripes still spinning outside barbershops today are a direct visual leftover of blood and bandages. Picture the toolkit for a moment, because this is where Doc gets involved. I put an 18th century phlegm on screen. It is a small spring-loaded blade built specifically for opening a vein in one clean motion. It sits next to a porcelain bleeding bowl with measurement lines etched into the inside. Doc adjusts his cracked monocle, leans toward the bowl, and goes completely still for a full beat. It is the same unimpressed stare he gives everything, except this time it lingers a half-second longer than usual. Even the timing of a bleeding was not left to guesswork. Almanacs printed across colonial America included what was called a zodiac man. It was a chart matching each part of the body to a sign of the zodiac. It told readers exactly which vein to avoid opening depending on the date. This was not fringe practice tucked in the margins of medicine. It was medicine, taught in universities, practiced by the most respected physicians in Europe. It was recommended for fevers, for headaches, for pregnancy complications, for practically anything a body could do wrong. And here is where the timeline gets genuinely strange. In 1628, an English physician named William Harvey published a book called De Motu Cordis. In it, he proved that blood does not get continuously produced from food and burned off by the body the way Galen assumed. Harvey showed blood circulates in a closed loop, pumped by the heart. It is the same finite supply moving in a circuit again and again. This finding pulled the floor out from under the entire humoral theory of bleeding. The whole justification depended on blood building up in dangerous surplus. Bloodletting should have quietly ended within a generation of that discovery. Instead, it got more aggressive. It took roughly 2 more centuries to slow down. That tells you something uncomfortable about how medical practice and medical evidence do not always move at the same speed. Nowhere is that gap more visible than in Philadelphia in the summer of 1793. A yellow fever epidemic tore through the city and killed roughly 5,000 people in a few months. Benjamin Rush, one of the most prominent physicians in America, was also a signer of the Declaration of Independence. He believed yellow fever was caused by excess tension building in the blood vessels. His solution was what he openly called heroic medicine. Heroic here does not mean brave, it means extreme. Rush drained blood from feverish, dehydrated, already weakened patients in volumes that alarmed even some of his own contemporaries. He sometimes repeated the procedure on the same patient within a single day. A journalist writing under the pen name Peter Porcupine, real name William Cobbett, published essays about this. He accused Rush's treatment of killing more Philadelphians than the fever itself. Rush sued him for libel and won in 1799. He walked away with a $5,000 judgment that effectively drove Cobbett back to England. That same year, 3 physicians stood around George Washington's bed at Mount Vernon. They made the same call Rush had been defending in court. One of them, Elisha Cullen Dick, was reportedly the most hesitant of the 3. Some accounts describe him proposing a tracheotomy instead, a genuinely forward-thinking idea for the time. He was overruled. The bleeding continued through the day. The swelling in Washington's throat never opened enough for him to breathe comfortably. By 10 that evening, the most famous man in the country was dead. Nobody in that room was acting out of cruelty or ignorance in the way we usually imagine when we hear the word quackery. They were following the most current, most respected medical theory available to them. They were applied by well-trained physicians, doing exactly what their training told them to do. That is the uncomfortable center of this whole story. It is worth sitting with for a second before we move forward. The next part of this timeline is where the practice actually starts to crack. In 1828, a French physician named Pierre Alexandre Louis published a study. It did something almost nobody in medicine had done before him. He counted. Louis tracked pneumonia patients who were bled early in their illness against patients who were bled later. Instead of relying on impression or authority, he compared actual outcomes across dozens of cases. His findings were quiet but devastating. Early, aggressive bleeding barely shortened the course of illness at all. In several cases, the patients who were bled less recovered just as well, sometimes better. This approach became known as the numerical method, one of the earliest uses of statistical comparison in clinical medicine. It planted a question European doctors could no longer fully ignore. What if the theory itself was never actually tested? I show Louis at a wooden desk, columns of patient outcomes written in ink across the page. He is tallying results one line at a time. Doc leans in over the desk, eye widening slightly at the growing column of numbers. It is a small reaction. Nothing dramatic, just enough to register that something in this room is starting to matter. Bloodletting did not vanish overnight after Louis published his findings. It would be inaccurate to say one paper ended a 2,000-year-old practice, but his work marked a real turning point. It was part of a slow shift across the 1800s toward medicine that demanded evidence instead of inherited authority. That shift accelerated further once germ theory reshaped disease itself later in the century. By the early 1900s, routine bloodletting for fevers and general illness had mostly disappeared from mainstream medical practice. Most people stop the story here. Honestly, this is exactly where competitor channels stop theirs too. Myth stated, evidence presented, and a tidy little bow tied around the word barbaric. I am not going to do that. Stopping here erases the part of this history that is actually the most interesting. The tool did not disappear. It got demoted from a universal cure to a precise, narrow instrument. It is used only where the actual mechanism of the problem matches what bloodletting can genuinely do. That is, remove blood from a body that specifically has too much of it. Consider the most literal descendant first, the one so ordinary you have probably had it done without a second thought. Every routine blood draw at a clinic traces back to the same basic act, a needle opening a vein. The goal changed completely, from removing blood as treatment to sampling it for information. That is a meaningful shift, but it is also the least surprising parallel here. Almost nobody would call a blood test barbaric. The next parallel sits much closer to Galen's actual logic, and it might genuinely surprise you. Hemochromatosis is a real, fairly common genetic condition. The body absorbs and stores too much iron. Left untreated, it can damage the liver, heart, and pancreas over time. The standard treatment prescribed in hospitals right now is called therapeutic phlebotomy. It involves removing a unit of blood from the patient on a regular schedule. That schedule is tracked through ferritin levels in follow-up blood work. Polycythemia vera is a bone marrow disorder that causes the body to overproduce red blood cells. It is treated the same way, with scheduled blood removal. That removal is used specifically to reduce blood thickness and lower the risk of dangerous clotting. In both of these conditions, a doctor is opening a vein and removing blood. The patient genuinely, measurably, has too much of something in their bloodstream. That is Galen's exact justification. It is just applied only where it happens to be biologically true, instead of applied to every fever that walks through the door. And this brings us to the closest parallel of all, the one that would have made Washington's physicians feel almost validated, if a little confused by the details. Hirudo medicinalis, the European medicinal leech, was cleared by the United States Food and Drug Administration. It became an official medical device in 2004. It is used today primarily in reconstructive and microsurgery. That includes procedures like finger reattachment, ear reconstruction, or skin flap surgery. Surgeons can successfully reconnect the artery feeding a piece of tissue. They struggle to reconnect the much smaller, more fragile veins draining blood back out. Without that drainage, blood pools in the reattached tissue, pressure builds, and the graft can die within days. A leech attached at the site feeds for roughly 20 to 40 minutes. Its saliva contains hirudin, a natural anticoagulant. It also contains compounds that keep local blood flow moving even after the leech detaches. This buys the tissue time, sometimes several days, for the body to grow its own new venous drainage. That new drainage takes over the job permanently. Patients typically receive prophylactic antibiotics during this treatment. Leeches carry a bacterium called Aeromonas hydrophylla in their gut that can cause infection if left unchecked. This is not a folk remedy slipped in quietly. It is a monitored, protocol-driven part of modern plastic surgery. Picture the two images side by side now, the way I would actually put them on screen. On one side, an 18th century porcelain bleeding bowl, ornate, catching blood drawn for a fever. That fever had nothing to do with excess volume. On the other side, a small glass specimen jar in a modern hospital surgical unit. It holds a single medicinal leech, prepared for a patient with a freshly reattached finger. Doc looks at the bowl, raises his cracked monocle a fraction with the same slow, unimpressed motion he has used the entire video. Then, without the shot cutting away, he turns and gives the exact same reaction to the leech jar. No difference in his expression at all, because structurally there is not one. Both images show a physician intentionally draining blood from a patient's body as treatment. Both use a tool designed for exactly that purpose. The only thing that changed across 2,000 years is precision. Galen's version applied the same solution to every symptom the human body could produce. He treated the theory as universally true because nobody had the tools or the framework to test it against actual outcomes. The modern version only shows up when the underlying mechanism genuinely calls for it. Iron overload, blood cell overproduction, or localized venous congestion that a scalpel alone cannot fix. That precision is the resolution here, the real answer to what actually happened to this practice. Bloodletting was not defeated and discarded. It was interrogated, narrowed, and kept exactly where the evidence supported it. That is a far less satisfying story than pure barbarism, but a far more honest one. So the next time somebody calls bloodletting a relic of a more ignorant era, you can tell them something. There is a decent chance a version of it is sitting in a hospital supply closet within a few miles of where you are standing right now. The gap between Washington's bedside and a modern operating room is a lot smaller than either of us would like to admit. If this changed how you think about a practice you assumed was settled history, tell me something. Tell me which medical myth you want dismantled next in the comments, and subscribe to Quackleed for more. Keep ingesting education.